I suppose I just want to firstly mihi to everyone. Thank you so much for the honour and privilege of being able to be here and to be a co-chair with my fellow colleague here, Markerita. We've got some really cringy slides about ourselves and we really don't want to put them up, but if we don't, our team will tell us off. So here's me, kia ora. I'm in the flesh and on the photo up there. I come here as the current Deputy Chief Executive, Public and Population Health, and the interim Deputy Chief Executive, Service Development for Te Aka Whai Ora, the Māori Health Authority, but came from a world that I suppose interplayed into many of the conversations that you've been having over the last couple of days, and with a really strong passion for Māori health equity.
And mā lole soifua, mau malangi mama, mā lole lei, kia ora ana koutou. Whakalofa lahi atu, nisa bulavi naka, tā lofa, tā lo ni, and I think if I've missed any, Māori, yes, hello, and I really would just like to say that we're here as Pacific Health, so I'm the National Director of Pacific Health for Te Whatu Ora Health New Zealand. Obviously I've had some partners in the room in the previous sessions, and it's a real privilege to stand here and to recognise the research and the work and the commitment that you have all had to create healthy environments and healthy lives for all New Zealanders, and we really just celebrate your work here today.
How do I turn that off now? There you go. Now you can just look at us. I've got just a little bit of a blurb I wanted to just start our session off with, and then I'll hand over to Markerita to sort of set the scene, I suppose, for some of the really important work that each and every one of you are contributing to, and that myself and Markerita do sometimes have a bit of responsibility for. E te rangatira tēnā tātou katoa. Ko Selah Hart tōku ingoa, ki te tau tōku pāpā, ko Ngāti ki te tau tōku pāpā, ko Ngāti Kuia, Ngāti Apa ki te rā tōrangi tāne o Wairau, Ngāti tōrangatira rau ko Ngaitahu, ki te tau tōku māma, ko Ngāti Kahununu ki Wairarapa rau ko Ngaitahu ahau. Today I stand before you to address the pressing issue that affects our society as a whole, culturally engaged healthcare for Māori and Pacific communities in Aotearoa New Zealand. It is imperative that we acknowledge the importance of achieving health equity for these communities, making research accessible to them, and addressing their future needs for culturally safe and supported research and health services. Firstly, let us recognise the significance of health equity. Every individual, regardless of their cultural background, deserves equal access to quality healthcare. Health equity ensures that Māori and Pacific communities have the same opportunities to achieve optimal health outcomes as any other group in society. It is not only a matter of justice, but also a matter of social responsibility. By striving for health equity, we are building a more inclusive and compassionate society where everyone has an equal chance at a healthy life. To achieve health equity, it is essential to make research accessible to Māori and Pacific communities and ensure that it is curated from the lens of those communities. Research plays a crucial role in informing healthcare practices and policies, and is looked at by decision makers when making critical decisions on healthcare services and the provision of healthcare for whānau. However, historically, Indigenous communities globally have often been excluded or marginalised in research processes. We must break down these barriers and actively involve these communities in all stages of research, from design to implementation and dissemination. This can be achieved by fostering partnerships between researchers and community leaders, ensuring the research is culturally appropriate and respective of traditional knowledge. By involving the voices and experiences of Māori and Pacific communities, we can develop research that addresses their specific health needs and contributes to improved health outcomes. Furthermore, we must address the future needs for culturally safe and supported healthcare services and the system as a whole. Culturally safe health services recognise and respect the cultural values, norms and practices of Māori and Pacific communities. It ensures that services are conducted in a manner that is sensitive to their cultural beliefs and practices. And in research, this includes providing appropriate protocols for engagement, ensuring informed consent and protecting the confidentiality of participants. Culturally supported research goes beyond cultural safety and actively promotes the empowerment and self-determination of these communities. It involves building research capacity within the communities themselves, enabling them to lead and guide research initiatives that are relevant and meaningful to their needs. We have a critical point in time to ensure we provide equitable outcomes in health and health research for all populations of Aotearoa New Zealand, and the special relationship and obligation of the Crown to tangata whenua. I acknowledge all of those that have spoken over the course of this hui, and I encourage you to continue to work hard as a collective as we steer our waka towards health equity. In conclusion, achieving culturally engaged health care for Māori and Pacific communities in Aotearoa New Zealand requires a concerted effort from all sectors of society. We must recognise the importance of health equity, making research accessible and addressing the future needs for culturally safe and supported research. By working together, we can ensure that these communities receive the care and support they deserve, leading to improved health outcomes and a more equitable society of all. Nō reira, tēnā koutou katoa.
Thank you, Selah. And a bit of context as to possibly why Selah and I are here as co-chairs is we do work really closely together, and we're also co-chairs of the process for the National Diabetes Action Plan that is currently under development. And so in the space of all things leadership, I'd just like to acknowledge Jim Mann and your leadership of a lot of the work that goes on to make healthier environments a real and living thing for us. I acknowledge Sir Jerry Mataparai, who's also in the room with us, and all the mātua who were here before. And we're really in a great space now for the final session of the day. And we've saved the best to last, certainly from our perspective. So, and so we're really starting to look at how the system gets involved in equity and how the system learns from both community and some of the research and work into assisting the system to do that, both at a framework level and a tools level. So it is with great pride that I ask Karen Bartholomew and Michelle Lambert to come to the podium and to present on implementing equitable health interventions, tools for use in Aotearoa, New Zealand. Welcome.
Kia ora koutou, ko Karen Bartholomew tōku ingoa. It's an absolute pleasure to be here today. Michelle is going to come up and introduce herself when she gets to her section. We are very much presenting on behalf of our rangatira Sue Kringle, who is the principal investigator on this study. And we do have a little video from Sue because we couldn't do this without her. But Michelle and I are very much not Sue, but we will do our best to present this work. So, my role in this, my day job is the Director of Health Equity in Service Improvement and Innovation in Te Whatu Ora. And my role in this project that Sue leads, the Healthier Lives project, is really the conduit into the system. So what Markerita was talking about in terms of translating what we learn into the system and being able to support its implementation in the system, and also to feed into the process some of the lessons that we've learned doing equity work in the system. And by that I mean particularly the mainstream system. So Sue was particularly keen in this work developed out of our kind of work together in the commissioning space when she worked in the DHBs, and that was really saying, how do we get the mainstream system to really think about equity? What do we mean by that? And so that's kind of how this work developed. So I'll be talking from that perspective, and then Michelle's going to tell you particularly about the project. And you can see up there all of the fabulous people who are involved in this research. There's extraordinary Māori health researchers and researchers with a huge amount of expertise, as well as the research team. So very, very privileged to be part of this project. So this is what we're going to cover. I'm going to do number 2 after we get Sue to do her little talk for you. And that's really, as Markerita said, we're just pulling up a little bit. We've just had such fantastic talks today from community perspective and hearing that stuff around co-design and the principles, and it's just been so fantastic to have that. And then the implementation network and really hearing those pilots and the stories and what people are learning around that communication and that connection. So we're pulling up a little bit from that into the systems and kind of frameworks and process. A little bit academic, so apologies for that. It's a little bit of an academic lens, but what we're hoping to do is pull through some of the really strong themes, both from Healthier Lives and particularly from this conference, about equity and about implementation science as a discipline. So I'm going to give you a little bit of an overview of implementation science as a discipline and how that might be able to help in the equity space. And then Michelle's going to go through the project and what we've learnt doing the project, and hopefully a couple of tools to help you all with your work that you do. So hearing from our rangatira.
Hei mihi nui ki a koutou, ko tai mai I roto I te kaupapa o te rā, tēnā koutou. He mihi nui hoki ki ngā kaiwhakahaere o tēnei hui, the Healthier Lives National Science Challenge. Tēnei tōku mihi ki a koutou. Ko Sue Kringle tōku ingoa, ko Takitimu te waka, ko Takitimu te pai maunga, ko te ara kiwa te moana, ko te takatau o te titi tōku marae, ko kaitawhika te manu me wataha oku iu. Kia ora. I'm delighted to be giving this very brief introduction to our team's presentation. Unfortunately, I'm on holiday and I'm very grateful that Karen Bartholomew and Michelle Lambert have stepped up on our team's behalf, on my behalf, to present this kōrero. We're talking to you about implementation science, which is the study of how to design and implement and evaluate implementation pathways for evidence-based interventions. We know that really good evidence-based interventions are often implemented slowly, sometimes not at all. We know from our experience in Aotearoa that when things are implemented, they often have inequitable outcomes from that implementation. In the late 80s, early 90s, there was a beautiful case control study done here in Aotearoa which identified key health promotion messages for whānau that could reduce the risk of their babies experiencing a sudden infant death. There was a fantastic national health promotion program rolled out with those messages, but it wasn't rolled out well, and the implementation of that program wasn't designed for Māori. And so what we saw was that it worked really well for non-Māori communities, but it didn't work so well for Māori communities. And so while particularly European rates really fell, Māori rates really remained the same, and we saw this massive increase in the inequity. The team I'm working with, we're really interested in making sure that these fantastic evidence-based interventions are implemented equitably. We also used Te Pikinga Whai Ora, which at the time was the only New Zealand-based implementation science framework, and a big mihi to John Etzel and Tanina Scott and their teams for the development of He Pikinga Whai Ora. It's a really great planning tool, and it's very community development focused. So we felt that in addition to He Pikinga Whai Ora, there was really a need for a tool that was for use in health services or the health system, particularly in the so-called mainstream settings, that was very equity focused. And so that's the work that we've been doing, our team, and we're very grateful to the Healthier Lives National Science Challenge for the funding and support that they've given us. And with that, I'm going to hand over to Karen and Michelle to kōrero to you about what we've done. Nō reira, ahakoa he mihi poto, he kōrero poto, he mihi tino mahana ki a koutou.
We're very glad that Sue is having a holiday, just for the record. She's in Botswana chasing wildebeest around, so she'll be having a fantastic time. So I'm just going to talk a little bit about high-level health equity. So Selah's given you the most fabulous description of health equity, much broader than what the Manatū Hauora definition up there is. But I just really wanted to acknowledge that there's a whole lot of equity parameters, and the tool and the work that Sue's been leading is quite specifically around ethnic-specific inequities. And I know all of you understand that, and I know that's what this conference has particularly been about, and Healthier Lives work has been about. But just kind of navigating that space, as Megan referenced before, the kind of navigating the current interesting times we live in, it's worth just stating again that ethnic-specific inequities are pervasive, they're ongoing, and they intersect, like Max talked about this morning, the kind of intersection of that range of equity parameters. And the ethnic-specific inequities persist even when you account for those other equity parameters. And I'm just going to show you one graph, because I'm a public health person, I've got to have a graph in here somewhere in a minute about that. But that's why we're focusing on ethnic health inequities. There's probably a whole lot of good translation that our work can offer to some of the other equity parameters, particularly rurality, socioeconomic status, but really just wanted to highlight that we were quite specifically looking at ethnic-specific inequities. And obviously there's a needs and rights perspective on that, and I've just put those up again just because it felt like it needed to be said again, that the rights-based reasons for health equity, apart from te tiriti, which again, I think it's worth just stating that again. The United Nations Declaration, Nina, I always hear Nina in my ear, making sure we put UNDRIP on there, and legislation. Obviously, we have the enabling legislation that we have, but also the Human Rights Act and the Bill of Rights. It's actually an obligation under that if we see, observe, research, record health inequities, that we actually do something about it. So we've got lots behind us for reasons for doing something about it. So here's my graph. This is just one graph, promise. So this is life expectancy and the program work I run in my day job, which I'm not going to talk to you too much about, despite people saying yesterday, Karen will talk to you lots about this stuff. I won't, but I'm happy to talk to people afterwards. The life expectancy gap there on the left, you can see the gap for Māori in blue, and so that's the gap in years between non-Māori, non-Pacific and Māori, and that's coming down, which is great. But look how big that gap is. If we kept going, it's 75 years to get to the no gap. And the gap for Pacific is flat. So not 75 years, but not going down at all. So what Sue and I have been talking about for a long time is what tools have we got to help the system accelerate the reduction in that gap. And that's where implementation science, we think, can come and help, or at least it can be one of the toolkit of things that we can use to address inequities. The reason I put the graph in the right up there, which is life expectancy by deprivation, so socioeconomic status, so Q1 being the richest to Q5 being the poorest on the right, is that it demonstrates really beautifully that intersection. So you can see at the top there, non-Māori, non-Pacific has got a gradient. So you're rich, you live longer. This is what Max talked about this morning. You're poor, you live a shorter time period. But then if you see the bottom, which is Māori, there is a difference at every single level of income. And more than that, the bottom of the non-Māori, non-Pacific is higher than the top of the Māori. So you can see that socioeconomic status is an insufficient explanation for the life expectancy gap. It tells us there's other things going on, and therefore there's other things that we need to think about. And there's boxes down the bottom just using the new rurality indicator, very similar picture for every distribution of urban to rural. There's also a life expectancy gap. So just wanting to remind people that all of those equity parameters, we deal with them in the intersection of them in all of our work day to day, and all of those projects and pilots that were presented this morning totally at the intersection of all of that. But it's an even bigger driver for why we need to focus on ethnic-specific inequities. So I'm sure you all know this, and I'm sure there's 1,000 reasons, and we could write them all from all of your presentations today about why we don't get action on inequity. Obviously in this room we're all interested in that, and we're spending our lives in this mahi. But there's lots of reasons why in a mainstream system, we don't get the kind of equity action we see. I've just put a couple of them up there. They're ones that I see in my work every single day. Pākehā paralysis is actually from Martin Tolich, who's a sociologist from the 90s, anyone who remembers his work. I just like that term because it's something that I see, which is system amnesia, system inertia, kind of feeling like you don't quite know what to do or don't know the answers, which we do, right? I mean, we heard all this morning that communities know the answer, we do know the answer, but there's this kind of paralysis. And then on the other side, and I've seen a bit of this too, we get performativity. So we get people doing equity things, but they're not things that actually make a difference to whānau on the ground. So, and again, I know you all know that. So when Sue and I were starting to have this conversation about what kind of tools, what do we need to overcome with implementation science tools, then it was trying to move from that thing that public health's really good at and the health system's really good at, which is describing problems and actually doing something about it and getting past this idea that people don't know how to do equity. And so giving some tools and enablers so we don't have people saying that anymore. So I quite like this model from detecting something to understanding it to acting. And we know where research can help all the way along the way there, and implementation can help as well, implementation science. So that's what we're really hoping that these couple of tools that Michelle's going to talk to you about are going to help with. There's always an iceberg, public health stuff, so here's a public health iceberg for you, either pyramids or icebergs, one or the other. So this is the work of Papa Arangi Reid and Bridget Robson. So really nicely encapsulates the drivers of inequities and the opportunities we then have in the system. And a lot of the work that you were all talking about today is very much in the determinants and the access to care space. The kind of space that we're thinking about for our work is more in the quality of care, moving into the access space. So this is the kind of, what is the system doing? Is it the thing that's going to impact equity the most? No, because we know the biggest is at the bottom of that iceberg, but it is the thing that we have direct control of for people who are in the health system and we can do better at. So, what is implementation science? Sue's given you a lovely definition. Here's a definition up there for you. But essentially, it's how do we get things we know work into practice? So, evidence-based practices, how do we get them into practice? And there's this kind of often quoted thing that it takes 17 years to get something we know works into practice. So, the idea of implementation science is here's a bunch of things that can help us make that go faster, which when we look at that life expectancy gap, we want it to accelerate and go faster. That's what we want. And there's a whole lot of reasons there. And you can see we've added cultural appropriateness in this reference. They don't talk about that, but that I think Diana mentioned earlier, cultural fit, that's a huge component of what we look at in the adaptation of implementation science tools. So I find this graph kind of helpful. In, I think it was Nick's talk yesterday, he talked a lot about efficacy and effectiveness, and we get stuck a bit there, but what we're trying to say is how do we go faster to the implementation bit at the end. And so implementation science as a discipline is interested in what things work for what people, and the equity aspects of that are how do they work for populations and how do we make sure they work at the beginning, like Diana said before, instead of coming in at the end and tweaking something. So here's 3 things I've learnt from doing implementation science studies and things that you can shortcut by learning stuff from what I did. So doing implementation science, you need to start with a description of the intervention strategy. This is a bit of jargon, sorry for jargon, but it is useful to hear some implementation science discipline jargon because then it can kind of help hang things on when you're talking to people who do implementation science. So I'm just going to talk very briefly about that and then a little bit about design and a tiny bit about TMFs. That is the commonest implementation science jargon. So there's a first one, implementation interventions. So it's the thing that you're trying to implement. And then the key thing about implementation science is the strategies. And that's where you can be explicit and you can study particular strategies and particular bundles of strategies. And that's really where we can offer the health system really good concrete research and intervention about what bundles of strategies work. So we are going to talk very, very briefly about lung cancer screening and its application to the tools that Michelle's going to talk about. And if we use that as an example, the CT scan is the lung cancer screening intervention, and the strategy of interventions is about how we invite people to the scan and how we support people through the pathway. So here's just a quick comment about design. When do you use implementation science? When do you use other things? I'm not going to talk too much about this, but this reference is awesome and I use it all the time. So if anyone's interested in doing implementation science, go and look up this reference. It's a subway diagram and it basically says if you don't know whether it works, don't do it. If you don't know whether it's effective, don't do it. But in the bottom, in the green, if you think it's probably effective and you want to learn how to the implementation strategies, that's when you use implementation science. Theories, models and frameworks are just representations of reality. That's all they are, but there's more than 100 of them, so they get super confusing. So we've found this categorisation really, really helpful, and Michelle's going to tell you about that. So essentially there's 3 different kinds, and picking a Whai Ora, just anybody who's used that framework, is a determinants framework. So it's the second one, and the one that we've developed is a process framework. So process is about guidance. The determinants frameworks are about understanding, unpacking what drives the outcomes, and then there's the evaluation frameworks. So in implementation science, people are just getting their heads around equity, but there's tons of papers coming out in the last little while, and so our work, we're hoping to contribute an Aotearoa specific contribution to that literature. I'm going to hand over to Michelle.
Kia ora, ko Michelle Lambert, toko whenua. I am the project manager and a research fellow on the project, and I'm a little bit nervous. So I'll just start with just an overview of our project and what we did. So we had 2 phases. We had phase 1 and phase 2, which we've kind of split into phase 2 and phase 3. The phase 1 we have completed. We did a scoping review of all the TMFs. We also did stakeholder and researcher interviews, so we interviewed 25 researchers and health professionals who worked in the intervention space about what they thought worked best with implementation and what they thought didn't work so well when they were implementing. We've also continued to do workshops with our kāhui and consumer groups throughout the time that we've been developing our tools. We have five Maori health experts, I guess we'd call it, including Andrew on our kāhui group, and we've also got about 6 consumers, the majority of them being Maori. I think at the moment 5 out of 6 of them are Maori. So we've got that nice balance of being able to find out what the experts think as well as whether they think that these will work from the consumer point of view. So we have developed an equity-focused implementation framework, which is what Karen was talking about, and also an equity readiness tool as well as a theory of change. In phase 2, we are in the process right now of testing those tools within the lung cancer screening area, and at the same time we will continue to revise the framework and the ERAT as we get that feedback, and also develop a user guide for people to use it later on. So just a quick overview of the scoping review. We did a thorough international scoping review probably close to 2 years ago now. We discovered 15 MTFs that had an equity focus of any description. Some of the 12 of them were equity focused. 3 of them were TMFs that had already been developed and were applied into an equity context. 6 of them were process models, and I think 3 were, no, it's on the next screen. So we have published that late last year, so there's a whole lot of information. I won't go through it too much. It's really complicated and really comprehensive. So this is our table that shows you how they all were. So we had 6 process models, 4 determinant, 3 evaluation, but the ones in orange are the ones that have been used most often. And I've got 5 minutes. So I'll just go quickly through some of the the ones that we looked at closely. This one is a determinant model. It is centred in the clinical encounter. It's the HIFE model, and you can see there's lots of the domains that are considered important are similar for each one. But I'll just flick through. And a lot of people have talked about the Aka Whai Ora, and I appreciate that Nina, all the good work that they've done on that. But as Karen said, it's about community engagement and making sure it's good for Indigenous people. We're going from the other angle with more of a mainstream perspective to try and get the mainstream thinking about the important determinants for Maori. This one is the Acquire framework, which is actually the one we adapted. So I won't go through it too much because I'll go through it when we're going through the adapted one. And also REAIM, I think a few of you may have heard of that. We didn't really consider it right at the beginning, but then in 2020 that we discovered this equity and sustainability extension, which is more in an evaluation model, but it has been used quite a lot in New Zealand. So the development of our equity framework, there were 6 steps. We did a literature review of the TMFs, as I quickly referred to just then. Then we did the interviews with the stakeholders and the researchers about what they thought was good implementation and how the things we needed to consider and make sure were involved in our framework. Then we selected the Acquire to adapt. And then we sat down as a team, a whole team, at a one-day meeting and looked at that framework and considered all the themes that we'd found in the interviews as well as in the lit review and talking to people that were implementation scientist specialists. And redesigned it a little bit, well, I quite adapted it a lot actually. And then the fifth step was to look at those interviews and make sure that in the adapted framework, everything that had been key themes was included. And then we went through the consultation again with the kāhui, looked back at the international research. So this is our framework. I know it looks a little bit complicated, but I've tried to break it down. It's very comprehensive, but as you can see, it is grounded in te tiriti, and the centre of it all is whānau health aspirations. It's underpinned by collaborative design, anti-racism, Māori and priority populations, cultural safety and values. And again, it's got the contextual influences which are fairly common in all of the ones that we found: social, economic, commercial and political determinants of health. And just another one, this is just the 4 sections. So around the outside it's a process model, so it's kind of a guideline of how to get an equitable implementation pathway. So you've got your 4 sections: implementation planning, designing the implementation pathway, implementation monitoring, and outcome and evaluation. And then you again look at the whānau and the health aspirations and start again, or move to the bits that you need to make sure are right. Again, that has just been published in the last month, so there's a reference there. And then, so the second tool that we developed is an equity readiness tool. So we identified a need for the mainstream of how to work and how to do equity work for mainstream services mostly. So we all know about organisational readiness and whether you're ready or not to implement intervention. And we also, probably most of us know about readiness assessment, which is tools that are already available. But after a search, we decided to use the readiness thinking tool as a basis, but we significantly adapted for New Zealand's. So the equity readiness is the willingness and ability of services, organisations to implement an intervention in a pro-equity way. So we've adapted an equity readiness, or we've adapted and developed this equity readiness tool that helps health staff in a team evaluate whether or not they're ready to implement an intervention. So there's 3 sections to it. There's self, there's team and service, and the actual intervention, as well as the bigger picture organisation stuff. It's a simple survey that's online. It's 29 self-rated items, and they all, the majority, there's self and then team, and there's quite a few. I think there's 11 in the organisation area. The aim of the tool is basically to generate a team discussion between everyone who's filled out the survey, and then to create an action plan to find out the things that they might not be ready to implement yet, and what they can do about that. Again, we've had it reviewed by the kāhui and the consumer groups throughout the development process. So there's just a couple of slides of what it looks like. It's got a couple of pages of introduction and how to and who should be using. As I said, we're really targeting the mainstream, probably hospital-type primary care people are where we're starting it. And then you go through the 3 sections. You can see it's a 4-point Likert scale, relatively simple. Everyone says it takes less than 10 minutes. So that's the phase 1, and now phase 2, where, as Karen said, we're in the process of recruiting lung cancer screening teams to go through the ERAP process and to evaluate how it works for them. We did a bit of pre-testing with a couple of Te Whatu Ora teams, and they were happy. They thought that the 10 minutes was realistic. Most of them took 6 or 7 minutes to complete it. We allocated 30 minutes for the discussion afterwards, but after these teams' meetings, we changed that to 40 minutes because we think that if there's not as much equity awareness, it might take us that little bit longer for people to get through it.
We had one team as a hybrid, so there was most of the team were in the room, but there were a couple who were on Zoom and they didn't see that as a big disadvantage at all. So that was good news because it's always hard to get clinicians in the room. Testing, we tested with the pro-equity team, so we thought maybe we do need a little bit more time for that. And there was a lot of people suggested that the ERAC could be part of a project development process. What else? And the facilitated discussion was the most important thing, and having a champion of someone who really wanted this to be used. So we are currently, as I said, testing with the lung cancer screening team. So our goal is to produce a tool that is simple and complete, user-friendly, and will help teams develop a plan to ensure an equitable implementation. I'm rushing through this, but what next? We're applying our framework with research teams, obviously. We're also in the process of developing a stakeholder group, which is appointed to build awareness in the more senior levels in Whatu Ora and other areas. And we are developing an implementation science workshop series, which will be held later in the year for people just to know a little bit more about it and how to equitably implement science, equitably implement interventions. And we're working with Karen and her team and others to try and see if we can get a train the trainer or support models for wider use. The summary. You can read it. Sorry guys, I was so talk too long. No.